And I'd like to welcome you now to session 1 with the title of Health Disparities. And again, this is a very wide-ranging number of topics around this central tenet of health disparities. And we know that research that fails to account for sex and gender, of course, leads to less targeted care and worse outcomes for everyone. And these 4 speakers will bring different perspectives to this. Karen Nakawala from Zambia, she's going to talk about the challenges of cervical cancer in low and middle income countries, particularly integrating healthcare services, community engagement and policy support. I live in the country that's aiming to be the first country in the world to eliminate cervical cancer. So we'll hear about how the setting influences a country's ability to try and do that. Rachel Fowden-hulme is going to talk about the inclusion of sex and gender in UK NICE guidelines and where they are mentioned and where they're not mentioned and what that might mean. Abigail Goodship will talk about the impact of the menstrual cycle on conditions that affect women. And Deborah Lawlor then is going to talk about inclusion of women in randomised controlled trials, of course, leading to the most important and highest level of evidence. How are they represented? So thank you. I'm going to welcome Karen, first of all.
Thank you so much. I wish you could go on clapping so that I settle down. My heart is pounding, but anyway. Okay, so thank you so much for the invitation to come. And I think for me, it's especially gratifying because I think persons with lived experience are very, very important in everything that we do. And for us to have a seat at the table, it just means that people are listening to what we're saying. People are listening to what we're feeling and going through, and not just assuming that because you've been to school and you've studied cervical cancer in my case, and you think that you know it all. And so I am so grateful for this opportunity. So as we grow up in life, there's always something that scares us. Whether it's falling off a bike if you're a young child.
So sorry, I'll just double check your microphone. I think we might have just...
But it's okay. So I was asking, we always have this one thing that scares us so much. It could be losing a child. It could be failing an exam. I did quite a lot of those. It could be losing a spouse. But I can tell you that the one thing that will always scare the hell out of you is a cancer diagnosis. No matter how strong you are, no matter how you think you can overcome anything, a cancer diagnosis floors you. And I remember telling my friends that, you know what, when I was told I had cancer, I think I literally knew Jesus at that point, because you start looking for anything that you think is going to help you. You start searching for something that you think is going to help you. You start clutching at straws until you think you find something that will help you. I was diagnosed with cervical cancer in 2019. And I vividly remember that day. I was a master of ceremonies at the official opening of one of the largest private hospitals in the country, ironically. And after that, one of my friends said, you know what? You're talking about all these machines that these people are brought here, so let's go and get screened. And I'm like, no, I'm okay. I don't have any symptoms. I haven't been sick. I've been eating well. I've been exercising. I'm healthy. So why should I go for screening? And she said, no, but let's just go. And she kept on. She's one of those, you know. And I thought the only way I'll get her off my back is if we go. Unfortunately, the gynecologist is a friend of mine. She delivered my last baby, 2010. And so we get there, we chat, we laugh. and I get onto the bed. The minute she sets the speculum, she has this strange look on her face. And I'm like, Doc, what's happening? And then she says, are you okay? I'm like, yeah, I'm fine. Are you in pain? I'm like, duh, I'm good. And she's like, you're bleeding. And the first thing that crossed my mind was, it's the speculum. She hurt me when inserting the speculum. And she said, no. There's actually something growing on your cervix. And I thought, I've read about polyps. It could be a polyp, And she says, okay, fine, you know what? Since you're smarty pants, let's do a biopsy or pap smear and see what comes out of this. And so she did that and asked me to go back after 7 days. She called me 7 days later. I went about my life. Like nothing was, wrong. And she says, Karen, it's cervical cancer. And I was like, oh, okay, all right. What does that mean? She says, you've got cancer. And my friends always laugh because the world can be falling around me and I'll have this huge smile on my face, And she says at that point I was smiling and she got afraid because of my reaction. But for me, that was just a reflex action. I remember getting into my car and driving home. It was about 7 p.m. And from nowhere, I just parked the car on the side and I broke down. I've never cried like that my entire life. The very next day, I had to go to the cancer hospital and everything started it was like an out-of-body experience because I wasn't given the time to literally sit and think, what happened? And I was lucky because I knew a few people who knew some people who knew some people at the cancer hospital. And so I'm one of the lucky few who started treatment within 3 weeks of diagnosis. But that was the longest 3 weeks of my life. And the first thing that crossed my mind was, I'm going to die. I have 2 daughters, and I didn't think they were ready to lose me. And I think after that, I was like, oh, what are people going to say? They're going to start pointing fingers at me because there's so much stigma that is attached to cervical cancer or any disease that is below the belt. That in my where I come from in Africa, that is, and we don't even talk about it because it's taboo. And so I was lucky I started treatment. And it's a disease that takes so much from you. It strips you of your humanity. It strips you of your dignity as a woman. And that is why a lot of women would rather die in shame. Africa has the highest burden of cervical cancer. 19 out of 20 countries that have the highest burden are in Africa. And I can tell you that only a fraction of the figures that you hear about actually seek treatment or even just go to the hospital for screening. In my country alone, my country, by the way, has the 3rd highest burden of cervical cancer, but doesn't have treatment. The time I was sick, fortunately, everything was fine. But a year later, everything broke down. So we have 3,640 women approximately that are diagnosed every year with cervical cancer. And out of those, 2,300 die. That's over 50% of women diagnosed. And these are just the people that I said seek treatment. Most of them choose to die at home. Most of them is because of the stigma that is associated with cervical cancer. The myths and misconceptions. Women don't want to go for screening because they think if they go for screening, their vaginas are going to get bigger. And when that happens, the men are going to take a run for it. They go and look for somebody with a tighter vagina. And so women don't seek health services at all. Others believe it's witchcraft. And others believe that, a lot of them believe that once you get a cancer diagnosis, you're going to die. And so you find a lot of women dying alone at home and in shame. For those that may want to seek treatment, in Africa, most families live under $1 a day. And so the woman has to choose between using that dollar to take herself to the hospital or feeding her family. And in most cases, they'll choose to feed the family. Even when they know that they have this disease, they choose to die. Others will want to get treated, but they'll get to the hospital, and guess what? There's no treatment. So it's like, I always say it's like being on death row. You just wait to die. You don't know when you're going to die, but you just wait to die. I know we're all going to die at some point, but I think there has to be dignity in death. I know too well what it's like to suffer embarrassing symptoms like heavy bleeding, smelly discharge, loss of weight, and all the bad things that come with cancer. And like I said again, I was lucky. I didn't get to that point. But now I work with those women every single day. I work with women who have lost their marriages because of a cancer diagnosis, because their husbands don't know better. I have worked with women who lost their lives. The doctors here will know when I talk about radiation. So during radiation, your vagina becomes tight, becomes literally very small. And it's raw from the radiation. But this woman gets home, and the husband insists, if you don't have sex with me today, you're gone. And this woman has no choice. She doesn't want to lose her marriage. And so she gives in. And that means she doesn't get better, because that happens over and over again, and eventually she dies. I had a woman, when I was having treatment, she went home and found her husband had moved her things into the children's bedroom and brought in a girlfriend, because according to him, she had cancer and she was no good to him. The next day she found she hung herself. And I was asking, we call each other sisters, where Mary was, and they said, no, you didn't hear? This is what happened. And so it's a disease that is killing women because of geographical location, for lack of a better word. Because I'm in a country where there is no treatment, it means I have to die. It's either that or I look for money and take myself outside the country for treatment. And that's going to cost me a good $5,000 to $10,000. But if I live under $1 a day, where am I going to get that? We have women that are being sent by the government to India and other countries for treatment. But it's a whole long list of people waiting, because it's not just cervical cancer that they're sending for treatment. It's all cancers across board. So like I said again, it's like being on death row. You just wait to die. As if that's not enough, I'm lucky enough to have finished treatment, I said 5 years ago. But you finish with the treatment, but the treatment is never finished with you. You live with side effects that can leave you so angry, so frustrated. Dr. Mary was talking about menopause, and I was like, okay. I knew about menopause. I didn't know what menopause was. I knew one day I'll be menopausal, but for me, it was radical menopause. And I remember one day waking up, I was at the salon doing my nails, and suddenly I felt like I was having a heart attack. And I called my boyfriend then. I said, you know what? I need to go to the hospital. Luckily, he was like 5-10 minutes away, and he drove to the salon. And he walks in, and I'm sitting there pretty, and the girl is doing my nails, and he's like, did you really just want me to come all the way, just, And the girl says, you know what? She was really dying. And so those are the side effects that you live with, There are days, I always joke about this, like the menopause is so bad. I think this morning I introduced myself twice to Elisabet. I met her outside. We introduced each other. I walked, she was right here, and I went, oh, hi, I'm Karen. And she'd be like, yes, we met. I'm like, oh, okay. And apart from that, it's the self-esteem that goes with it. The body image, your body just starts to change. The other day I was teasing my friends. I said, you know what, this menopause, my body is changing so fast I can't recognize it. When I'm changing, I'm alone in the bedroom, I literally hide behind the door so that I don't see myself changing, The sexuality is affected. And most women at this point, as I'm speaking, I've got a project I'm working on trying to find out how we can include partners, in counseling, because women are losing their jobs, because after treatment, your vagina becomes small. I think they call it stenosis. The clever ones here will know. But women lose their marriages. Women lose their standing in society. You just lose yourself. Like I said, it just strips you of everything that you know as human. Your life, it's good to be alive. I'm grateful to be alive, but my life is not the same anymore. My quality of life is not what I knew it before. I have to learn things every single day about my body. We literally have to compromise. Okay, you know what, today, just be kind. I need to do this. Don't disturb me in any way. You lose you in the process. And there's so many women that are dying, not just in Africa, across the world. I don't know how bad the stigma here is, but in my part of the world, it's usually because of lack of access to treatment, lack of access to screening services. I think in the West, it is much better than where I come from. But at the end of the day, cancer diagnosis is just a cancer diagnosis, and there's no two ways to look at it. A lot of people think it's a death sentence, but it shouldn't be a death sentence. We need to encourage our women to get screened, to seek good, health-seeking behaviors, so that we don't leave children behind. Like I said, when I got my diagnosis, I thought I was going to die. There's so many maternal orphans that are being left behind because of gynecological cancers in Africa. We have too many recurrences. You're lucky to go past the 2-year mark. When I went past my 5-year mark, oh boy, didn't I have a celebration. And people didn't understand why. That's because I am lucky to be alive. I am lucky to be here today. And so I hope when you're looking at me, you think of all those statistics that you talk about or hear about. They represent a face. They represent a person like me. They represent a woman out there who didn't get a chance at life, who couldn't get treatment. They represent a woman out there who may want to get treatment, but she can't. Not because she doesn't want to, but because it's not available, or because it's too expensive. Those statistics represent a face. They represent a human life. And that is why I'm so happy and grateful to be here. At least you can put a human face to cervical cancer. And I know a lot of people think when they hear cervical cancer, they just think, oh, I'm going to see a person that looks like she's about to drop dead, or the wind can just blow her in one direction or the other. There is life after cancer. And I know that people in this room will do whatever it takes to help us find the solutions so that we can save the millions of women out there. I've been talking for the last 15, 20 minutes, and I can tell you that every second minute, a woman dies from cervical cancer. You can do the math. One woman is too much. We've been here since 12:30, and every second minute from 12:30 to now, a woman is dying every minute. I think that is unacceptable. Until we start to place importance and value on our women, we're not going to win the war against cervical cancer. The World Health Organization has set the target 90, 70, 90, to have 90% of girls vaccinated with the HPV vaccine, 70% of women screened with high-performance tests, 90% of women found with disease treated and managed. But in Africa, that's a dream, that's a song. We're talking about universal health coverage in Africa, that is a song. Very few countries are actually managing that. Very few countries are able to offer cancer treatment. Forget cervical cancer alone. So until we do the right thing, we're going to keep losing the women. And I think that women don't deserve to die from cervical cancer. They don't deserve to die in shame. But we need to start talking about it all the time. We need to have these conversations with our families, with our colleagues, at work, wherever. We need to talk about them. And our children deserve a cervical cancer-free future. I could go on and on and on and on, but I'll save you. Thank you so much.
So fantastic to have the human aspect of what we are discussing here. Are you happy to take a question?
Yeah, sure.
Yeah. Does anybody have a question they'd like to ask? I might ask something. So what you've talked about really is the misogyny that drives the disease. How do you see, this is a really big question, what would, if you were able to do something to address that, not just the treatment, but the driving force, what would you do?
I think we need a lot more advocacy. I think I'd focus on that. I'd focus on community engagement, and which is what I'm doing back home. And I'd also, when people hear stories like I've bored you with my story, they're moved into doing something. When I hear it from Martha, because I know she went to school for it, I'll be like, Yeah, but if somebody with a lived experience comes up and tells you, guys, you need to do this because of A, B, C, D, I think you get scared and you eventually do something. So I'd like to use a lot more people with lived experience to sort of be the agents of change in their communities, as champions. I think that's what I'll do. Yeah.
Okay. All right. Thank you. Thank you. Thank you.
Thank you.
So now I'd like to welcome Rachel from the George Institute, who's going to talk about how in our guidelines for health in the UK, how much or whether we consider differences in sex and gender. Thanks.
Thank you. Thank you. Can everyone hear me okay? Brilliant. So thank you for having us here today for this Women's Health, Genes and Data Conference. My name is Rachel Hume. I'm a former civil service policy professional, now in my penultimate year of retraining as a graduate entry medical student and a research assistant at the George Institute, which is hosted by Imperial. We, as the Wellcome-funded Medical Science, Sex and Gender Equity, or conveniently MESSAGE project, are excited to share with you today the results of our systematic review into how sex and gender dimensions are accounted for in NICE clinical guidelines. So we know that sex and gender are under-considered at all points in the research pipeline, leading to certain groups being underserved in clinical practice. We also know that these groups are typically women and girls and trans, non-binary and intersex patients. One of NICE's key roles is to gather evidence and through expert committees, synthesize research into clinical practice guidelines to aid clinicians in delivering effective care to all patients in a standardized manner. However, recent reviews of clinical guidelines in Canada and in Europe have identified that both limited and inconsistent attention has been paid to sex and gender dimensions in diagnosis and management. So despite underrepresentation in research, we know that there is work that disaggregates by sex and gender really well. And many researchers are really pushing this more inclusive, evidence-based research approach. So we wanted to investigate how effectively this existing research is being translated into tangible guidelines for clinicians to use in their day-to-day clinical practice. Unfortunately, and as expected, this study identified significant gaps in how NICE account for both sex and gender across all clinical specialties and also across all aspects of disease presentation and management. So in the interest of accuracy and inclusion, here we use sex to denote biological characteristics, including but not limited to sex chromosomes, gene expression and hormone profile, and gender to reflect the roles, behaviours and identity a person assumes in society. So this study reviewed all 223 guidelines listed as clinical guidelines by NICE as of July 2024. I'm conscious a couple more have cropped up since then. We initially excluded the 26 solely linked to single-sex conditions, such as prostate cancer, leaving 197 for full data extraction and analysis. And then to align with those comparable Canadian and European reviews, researchers evaluated inclusion of sex or gender dimensions of disease pathophysiology, epidemiology, clinical presentation, investigations, and management. The study also examined if sex and or gender were included outside of pregnancy considerations, if terminology was used accurately and consistently, and how the gender of guideline committee chairs influenced this inclusion. So also to align with pre-existing research, reviewers used a detailed protocol to grade the extent to which guidelines considered sex and gender dimensions. So we can see here, maybe I'll get my little pointer out, you can see here we've got a score of 1. Yeah. So we've got representing the most consideration, so evidence-informed recommendations that support different or shared approaches for men or women, whereas 5 represents the least consideration, so no mention of sex or gender or any of the predefined keywords identified as relevant search terms. So results of this review offer a baseline assessment of how the UK's clinical guidelines consider sex and gender. Notably, we only have one guideline that provided evidence-informed recommendations that support different or shared approaches for men and women. 77 guidelines, or 39%, failed to account for sex or gender at all. And from a different section of the protocol, so not on this graph, only 81 guidelines, or 41%, considered sex or gender beyond pregnancy and childbirth. Looking to the different disease aspects considered, of 197 guidelines, only 4 included evidence-based sex or gender differences or similarities related to the disease pathophysiology, 38 related to epidemiology, 18 related to disease presentation, and 19 related to investigations, so clinical scoring systems or lab values. 73 guidelines mention sex or gender dimensions in relation to treatment and management, but of those 73, 42 related solely to management in pregnant and breastfeeding women, typically specifying medications or procedures to be avoided. In relation to the committees responsible for developing and updating guideline content, of 162 published committee chairs, 75% of those were men. Women were better represented in non-chair positions, where 48% of committee members and 65% of lay members were women. And we did find that guideline committees chaired by women, on average, achieved a better rating for sex and gender consideration. So to our discussion, the study found that when evidence was known to be lacking for males, this would be explicitly stated in the guidelines. By contrast, no such clarifications were identified when evidence was missing for female patients. And this finding reflects the male default in medical research and clinical practice. Management recommendations for women often represented what procedures or medications should be avoided, rather than providing alternative solutions. And this supports the presence of a precautionary principle which focuses on reducing medico-legal risk rather than considering the opportunity of untreated or undertreated disease in pregnancy. Similarly, when sex and gender differences were mentioned, this was often in reference to how conditions interact with pivotal stages of the female life course. Such as menarche or menopause. This does underline the clear need for a life course approach that looks at how age intersects with sex and gender in women's health and during these life course transitions. However, having said that, women's health encompasses so much more than just these life course transitions, and it's vital that the health of all women beyond these pivotal junctures, and crucially outside of pregnancy and fertility and childbearing, is adequately addressed. The majority of guidelines also failed to use sex or gender terminology accurately or consistently, often using gender-related terms describing features that related to sex. Only 3 guidelines included definitions for the sex and/or gender terminology used. Only 8 guidelines referred to trans, non-binary or intersex health. This reflects wider trends in the medical evidence base, often rendering these groups invisible in study samples. It's vital that these patients, already known to be extremely underserved by healthcare systems and vulnerable to knowledge gaps amongst clinicians, are made visible in guidelines. Also, for guidelines categorised by NICE as health and social care delivery, they showed on average less consideration of sex and/or gender than those categorised as conditions and diseases. It's key these dimensions are considered in delivery aspects of healthcare services and the social care landscape, especially given the relatively more vulnerable status of those reliant on the social care system. Finally, we found that when women were the guideline chairs, the guideline was more likely to account for sex and gender. Although there was more representation of women in committee membership and lay membership, as we saw, women remain underrepresented in those more powerful and more influential chair positions. And this is reflected in UK health leadership more widely, where women remain in the minority despite making up the majority of the healthcare workforce. This review demonstrates considerable gaps in how NICE accounts for sex and gender, suggesting that NICE has not accounted for these critical dimensions in a standardised and systematic way. As a single body that's dedicated to guideline development, which is a rarity in some healthcare systems, NICE has a unique opportunity here to pioneer robust mechanisms to promote more accurate, inclusive, and crucially evidence-based healthcare recommendations. The NHS has a long-term goal to provide personalised medicine, but until these critical aspects are accounted for, providing intersectional and personalised healthcare remains a distant possibility. As message, we call on NICE to identify existing key evidence on sex and gender dimensions across all clinical specialties. Some of our recommended initiatives include a large-scale consultation, a systematic review, and engagement with leading experts. This should ideally identify existing key evidence, and then based on those findings, NICE should publish recommendations to highlight the most urgent and pressing data gaps. NICE should also establish a mechanism to regularly embed relevant sex and gender disaggregated evidence in guidelines and, importantly, flag this to their users. In particular, NICE should include a mandatory specific question on sex and gender in all future guideline consultations published. And we further encourage NICE to expand their equity responsibilities to consider race, ethnicity, age, and how these intersect. Ultimately, meaningful change will require systematic and whole sector progress to integrate these sex and gender disaggregated research into clinical practice guidelines. And this conveniently leads us to a brief plug for Message's wider work, which brings together funders, regulators, publishers, and also researchers, clinicians, and patients. Message is a UK flagship policy initiative bringing together the research sector to improve integration of sex and gender in biomedical, health and care research. Over a series of policy labs, Message has led co-design on a sex and gender policy framework for UK research funders, which sets a new gold standard for excellence and equity in research practice. The policy framework, reports and our supporting educational materials can be found on our dedicated project website, and we'll also be presenting our work at a poster here tomorrow, and we'd love to chat over the coming days with anyone who'd like to discuss our work further. And finally, with huge thanks to Message colleagues and to welcome Imperial and the George Institute for their funding and support.
Thank you, Rachel. That's fantastic. I mean, NICE they can change. They've recently introduced independent chairs, which, in my experience on the committee, makes a huge difference. So there's a bit of hope. Does anybody have any questions? Rachel. Hi, Gita.
This is just a One second, I think you need the mic for those online.
Thank you. Thank you, Rachel. One of the things, this is just a note, that more recently the National Health and Medical Research Council, so it's similar to your MRC, has stipulated that all grants consider or at least comment on how they've taken sex and gender into account. So I think, we are aware, getting aware of it and adopting this. So just a comment.
No, and that's great to hear, and that's exactly the kind of funder policy frameworks that Message are working on. The project actually spawns the data that in 2021 in the UK, there wasn't a single medical funder that had a policy that mandated even the question on sex and gender. And so we are cognizant that the UK is actually in these areas sort of lagging behind some of our international comparators.
And it's just a recommendation for NHMRC. It's not a policy as such. Okay, great. Sorry, hang on a second. Is there any questions online?
No, I will tell you.
Okay, good. Thank you very much. That was great. So now, hi, Abigail. Abigail's going to talk about the impact of the menstrual cycle, the association between the menstrual cycle and conditions that specifically affect women, particularly COVID and ME. Thank you.
There we go, it's coming up. Brilliant. Can you all hear me okay? Brilliant. Long COVID and ME/CFS disproportionately affect women. We know hormones influence many female-dominant conditions, so how might they be affecting these two diseases? My research explores this question, investigating how the menstrual cycle and hormonal contraception may influence symptoms experienced by women with long COVID and myalgic encephalomyelitis, ME, also known as chronic fatigue syndrome. So during this presentation, I'll refer to it as ME/CFS. A clear sex difference exists with long COVID and ME/CFS. They both affect around twice the number of females compared to males. Long COVID has wide-ranging symptoms, including fatigue, brain fog, muscle aches, and these symptoms closely align with that of ME/CFS. Both diseases are thought to have a viral origin, and they involve dysfunction of the immune system. They can profoundly impact quality of life. For example, around a quarter of individuals with ME/CFS are housebound. Despite the deep impact ME/CFS can have on quality of life, research into the disease has been consistently underfunded. In this figure, each of the bubbles represent a disease, and the size of the bubble represents the disease burden. If we look at this end of the axes, on the x-axis, then it represents low funding, and as you go up, you get more funding. And as you can see over here, right down the bottom, we've got chronic fatigue syndrome. And this is true for so many other female-dominant diseases you can see on this top line here. Given this lack of funding and research, and also the recent emergence of long COVID, as well as the complexity of both diseases, there's still much we don't understand, including how symptoms are affected by ovarian hormones. Ovarian hormones fluctuate over the menstrual cycle, as you can see in this diagram here. And we already know that estrogen and progesterone are modulators of sex differences in immune function in other diseases. Given the immune dysfunction in long COVID and ME/CFS, this suggests ovarian hormones could modulate symptoms. Phases of the menstrual cycle have been shown to correlate with a cyclical pattern of symptoms of chronic and particularly autoimmune diseases such as rheumatoid arthritis. But before this study, it was unclear whether sex hormones modulate disease symptoms and whether symptom severity changes over the menstrual cycle in long COVID and ME/CFS. As I said, evidence was limited, but we did have some work on acute COVID-19, suggesting that estrogen could be protective, so with combined oral contraceptive pill and also HRT seeming to be beneficial. There was a bit of research on long COVID. There are 2 studies that included a single survey question, which found that some long COVID patients reported their symptoms were worse in the premenstrual and the menstrual phase. But these were single survey questions, and surveys are limited by recruitment and recall bias, and the impact of the menstrual cycle on MECFS hadn't been investigated to our knowledge, and nor had the effect of hormonal contraception. Compared to surveys, app data is less likely to be affected by recall and recruitment bias because data is entered in real time as part of individuals' healthcare routines. Visible is an app that allows users to track both menstruation and the symptoms of long COVID and MECFS. So in this study, I used prospectively collected data from Visible to test 2 hypotheses. Firstly, that long COVID and MECFS symptoms will be worse during the menstrual and the premenstrual phase, and they'd improve in the mid-luteal phase. And secondly, stabilising levels of ovarian hormones using hormonal contraception would be associated with improved symptoms. Each day, users were prompted to self-report their commonly experienced symptoms on a 4-point Likert scale, and they were also asked to say whether or not they were currently experiencing their period or a crash. I cleaned the data, removing any users who were pregnant, breastfeeding, outside of our age range of 18 to 45, and I also removed any cycles that were missing data or of irregular length. I also built a simple algorithm to assign menstrual phase to each day. After data cleaning, I had 4,450 cycles, and these came from a total of 948 users. And you can see these were the different disease groups that we had. So we had long COVID, MECFS, and people with both diseases. The demographic information, or the demographics between these study groups, wasn't significantly different. So, on to the results. We used a negative binomial mixed effects regression model to look at overall symptom score and menstrual phase. So overall symptom score is essentially the sum of all symptom ratings for a given day. And we adjusted for differences between individuals, disease type, age, time, reproductive history, and contraception type. And you can see this graph here illustrates what we found. So there is a cyclical change in symptoms over the cycle, but these are small changes. For example, symptoms are worse during the menstrual phase, and they're around 4% better in the early luteal phase. We also investigated the association between menstrual phase and crash incidence. Crashes are the sudden and severe worsening of symptoms following exertion. And we found crashes to be highest in the menstrual phase, with the odds of a crash occurring in the late luteal phase to be around 11% lower. So on to my second hypothesis on hormonal contraception. So in both of the 2 mixed effects models that I've already shown, we included contraception type as a fixed effect. And we found that symptoms were 17% lower in users that were on combined contraception compared to users that weren't on hormonal contraception. And arguably the most interesting finding, that the odds of a crash occurring in users on combined contraception were 45% lower than users not on hormonal contraception. Users on progestin-only contraception didn't have significantly different scores or crash incidents when compared to users not on hormonal contraception. So, to summarise, this study, to our knowledge, is the first to describe changes to long COVID and MECFS symptoms across the menstrual cycle. We found that symptoms are worse during menstruation and least bad just after ovulation. Also, to our knowledge, this is the first study to investigate the effect of hormonal contraception on symptoms of long COVID and MECFS, and we found that combined contraception was associated with significantly ameliorated symptoms and a reduced risk of crashes. I do think it's important to note a couple of limitations with this work. Firstly, participants were selected based on ease of access. And secondly, the user base of the app Visible means that there aren't any healthy controls. So, whilst our findings do show that for affected individuals, they may experience cyclical symptoms, we can't be sure if this is the direct impact of ovarian hormones on the disease, or whether this observed change in symptoms reflects normal variation in well-being across the menstrual cycle. Irrespective of this, these findings suggest that it could be beneficial to people who have long COVID or ME/CFS to schedule more strenuous activities during the phases of the cycle where they are likely to have milder symptoms and may be less vulnerable to a crash. Also, our finding that combined hormonal contraception is associated with lower symptom scores and fewer crashes may inform the use of contraception in people living with long COVID and ME/CFS. Also, this contraception finding does suggest that potentially ovarian hormones are directly modulating the disease, but there's definitely more that needs to be explored there. If you're interested to read more, we've just submitted a preprint. Unfortunately, we only submitted it on Friday, so it's not gone live yet, but it should go live in the next couple of days. I also do have a couple of paper copies as well, so do come and chat to me if you want to read it. I'd like to say a huge thank you to all of our study participants at Visible, and also to Rory and Harry, who are part of the team at Visible, for curating our data from the app, and also providing insights as people with lived experience of long COVID. I'd also like to thank my supervisors at Imperial, particularly Vicky Mail and Christian Morgenstern, who've supported me throughout this project, and also to the Medical Research Council for funding me as a PhD student. Thanks so much for listening, and let me know if you've got any questions.
Thank you, that was great. We've got lots of questions. Question here, please.
Thank you. Really wonderful talk. Congratulations. I have two questions. One is, did you take into account the different types of symptoms, of whether they all varied in the similar way? And then the second question is whether you took into account how long they had been taking contraceptives.
Two very good questions. So on the first question, for individual symptoms, we ran models for each of the individual symptoms. So there were 36 different symptoms, and we found that for the majority, so off the top of my head, I think it was 25 out of the 31 out of the 36 symptoms did show a significant association with menstrual phase, and it was around 22 that showed the same pattern of it being worse during menstruation and slightly better around ovulation. And then your second question was, maybe remind me on the second question.
How long they've been taking?
Oh, yes. This is a brilliant question, and this is a limitation of the work. So basically, when users consented to be part of the study, then they filled out what contraception they were on. But we don't have daily information on what contraception, whether they changed. So that's a really great point to make.
Thank you. Thank you. There was another question, I think. Hi, over there. Yeah.
Thank you for your talk. I was wondering if you have information about the concentration of the hormone in the contraceptive pills, and also like if, for example, microdoses pills have the same effect as the normal pills.
Yeah, again, a great question. So we did have information on what type of contraception people were on, like whether they were on combined pill, whether they were on the coil, whether they were on progesterone-only pill. So kind of we didn't have like particular brands of pill. But unfortunately, with our numbers, we just didn't have sufficient power to look at each of the individual types of contraception. But I think with a bigger cohort, I think that would be something that would be really good to look into.
Thank you. And we've got an online question. Lisa?
Yeah, it's not an online question, it's more a comment. So thank you. As a scientist who has rheumatoid arthritis, I tried for years to communicate with my physician around correlation with menstrual cycle. This is validating to hear of your study. Can't wait to read about it. So that was more a comment. So is there any final
other
questions?
Hi, one here.
One more question.
That might be the last, yeah. You'll be here when you need to take it.
Oh, yeah, sure, yeah.
Okay, thank you for your talk. It was really good. I was wondering if, this is very cool. You can get, I don't know, information about their hormonal levels, more biological information rather only just symptoms. So you can, I don't know, find some potential biomarkers or some correlation with the hormonal levels. Are you planning to do that?
I mean, I think that's a great question. In terms of immediately, we haven't got a study planned where we've got kind of blood samples, but I think that would be really useful. We do have a few more extra bits of data from the app, we've got heart rate variability, so that's something we could look into as well. But yeah, no, I would love to do a study looking at actual hormone levels.
Great. All right, thank you.
Thanks so much.
So next, I'm really delighted to welcome Deborah Lawlor, who's going to speak to us about inclusion of women in randomised controlled trials. And as a Cochrane editor, we worship at the feet of randomised controlled trials. And it's going to be alarming for me to realise when Deborah speaks that they're not as good as we thought they were.
You don't know. Thanks very much. And just to say, organisers of conferences don't normally pick themselves to speak, and we didn't. Unfortunately, Camilla Stoltenberg, who was going to talk about sex and gender differences in education and the role of that in health across the life course, which is a fantastic talk. I've seen her work. It's not what I'm going to talk about. And I think we'll probably catch up on time because this is some very early thoughts and results, but useful to have any people's comments and discussion. So there's a long history, and if we go back into ancient times, then we know men and women were treated very differently, and women had very few roles in any kind of research. That's changed over time. Nonetheless, it was only until the 1970s that there was any kind of sense that there ought to be at least equal numbers of women and men in research. Before that, there was nothing that sort of suggested that should be the case. And even with that increasing understanding and knowledge, there's still continued evidence that women are less represented in randomised controlled trial. And going back to Rachel's talk, there's a lot of synergy here, and we didn't coordinate because we've never met before. I used gender/sex in my title. Nothing in the literature that I read on this thing has used anything other than women, men, or males and females with no definitions. And I think that sort of reflects the history, and my research is the same in that regard. One of my interests in going back a little bit about this is because much of my work currently is around the kind of, in a sense, massive inequalities, but understandable again, the fact that we know very little as clinicians what to do when a woman becomes pregnant and she's already on various treatments, and autoimmune conditions have been talked about, and they're particularly common in women of reproductive age, but I'm not going to talk about that today. And again, reflecting what Rachel was talking about towards the end, this sort of edict, which came from a group of policymakers, clinical groups, WHO, that research should reflect the populations for whom it's going to be relevant. And what I'm focusing on today is women and men, but there's a much bigger picture around ethnicity, different gender groups, and I think often the most discarded is socioeconomic inequalities. And I think in part that's because people say it's so hard to collect those data, but in some ways that's not a good enough excuse, and we need to do more and need to do better. So this was a UK government initiative, and it focused on statin trials because they were the things that were being done in large numbers at the time. And it was led by Shai Ibrahim, who is now retired, an emeritus professor, was at University of Bristol, was one of my PhD students. And they were looking into the enrollment and exclusions. And again, I should have said, I've used enrollment because it's the kind of endpoint I'm interested in. And what you can see here is that 20% of the statin trials that they looked at that time period excluded women completely. But then when you went on to look at the enrollment, and they looked at this in various different ways, what you would expect is that around 50% of participants in randomised control trials would be women and men if there's no over-selection or lack of response. And what they found was this was 19%. And then more recently, this has been looked across in time, and it's improved in terms of the overall percent who end up in a randomised control trial, but it's still not what we would expect. And from these two, the report and this study, it seems to be a mixture of some exclusion, for example, not necessarily excluding all women, but excluding women who are of reproductive age and are planning to get pregnant, or women who are lactating. But it's also a lower response from women. And for me, that's something I find interesting, and we know so little about it, as far as I can tell. So in terms of why there may be some contribution to this, it does relate to pregnancy and lactation. And that's not solely from pharmaceutical industries and clinical researchers. It's also from the couples. Many couples, understandably, completely understandably, I think few would disagree, are not that keen on volunteering to be experimented on when they're pregnant, or when they're planning to be pregnant, or when they're lactating. And there's then been these sort of situations that make you realise that can lead to big problems later on, but also it leads to problems here and now when you see a woman who is on medication and we don't know what to do. So that spills into then the bigger picture of women in general. And what do we, I think largely the answer is we don't quite know why this happens, but the sorts of things that are hypothesised and make some sense are it's clearly question specific. So some of the things that were talked about in the report on statins, and it's not that data are being collected on this, it's just sort of notions, ideas, sometimes some qualitative research, are that heart disease was seen as something that didn't affect women, and so they would be less likely to go into a trial. The other hypotheses are much more around sex or gender, suggesting that there is this sort of difference in terms of their place in research and who the researchers might be. And again, it's relatively recent that there have been more or less similar numbers of academics who are women and men. And if what you're seeing in these trials and being invited to is sort of men, you may feel put off. Or, as I've mentioned, women not partaking because they may be thinking of getting pregnant. So then my thoughts go to, well, what about experimental studies in animals where we mightn't expect any of these to have a role? And this is, Gemma Sharp is here and is, just to embarrass her, not intentionally, one of my heroes for the way that she works, the thoroughness of the work and the ideas she comes up with. And this was some work I had the pleasure of working with her that built on a piece around how the developmental origins hypothesis had put a huge emphasis on women and how they were controlled, and it really was about control, during pregnancy. When you read the headlines, were solely responsible for their developing fetus and hence the children going forward. And to me, it's scientifically wrong, it's offensive to women, it's also offensive to men, because fathers, partners do have a role in supporting the pregnant women and have a role preconceptually. So having sort of Gemma led that initial piece, we thought it'd be useful to systematically review the literature and across the developmental origins research, look at how often just the woman was considered, how often the woman and the man were considered, and other partners, and so on. And there was a moment where we were sat talking about the protocol for this, where there was a kind of, one of us, can't remember who said, and it's humans only. And I think all three of us paused and looked at each other and then thought, oh, no, we look at the animal models as well, because there is a lot of DOHAD research in lots of different animal models. And at the time I thought that will give us some insights into where we should be looking in terms of the partner, the male contribution. But what was shocking was, even in the experimental animal models, it was pre-assumed that this was all on the woman. And it's a nice paper. Gemma made this automated thing where you can put in, if you want to look at animal models, which animal models, various other parameters to explore where you see these kinds of differences. And then also, what about observational studies? So these are two prospective cohorts around cardiovascular disease in the UK, and you'll see the first one started recruiting in 78. The second one is the study where I collected data and was central to my PhD, so it came on board much later. What is the point here in relation to this topic is that the original British Regional Heart Study, the grant went into the MRC, and this is in a long time ago, led by Jerry Shaper, and it was to include women and men. At the follow-up that was done then in kind of early 2000s, that was being planned, that was the first time they'd managed to persuade any funder to allow them to pick up the women who would have been in. And I remember talking to Jerry at the time I was starting my PhD, and he showed me the MRC letter where they had put in the grant application to do women and men, and the sort of top line was, congratulations, we're going to fund your study, but only for the men, so this is the new amount of money you'll get for it. And then you got the reviewers' comments, and they were interesting because they fell into two camps. The one camp that said, take out the women, they'll add all sorts of noise, all those hormones. And that kind of comment always makes me laugh, because it's like, what, the men don't have hormones? And it links to Anna's talk today, where you sort of picking up these biological paths, these genes that relate to oocyte numbers and fertility in women, but seeing their relationship in men. So we have to think of all of the people that it's relevant to at the time. There's this one group that's saying this, which to me implies that they were thinking there are sex differences, which would argue for keeping the women in. And then the other group who said, it's too rare in women, we need too larger numbers. And they were just asking for, men and women, not sort of saying what proportions they were going out to do a cohort. And anyhow, they'll have the same results as the men, so diametrically opposing. I think and hope that wouldn't happen these days, but this is not when you're experimenting on humans. This was a cohort some decades ago, but relatively recently. And this is an area that the NIHR, who I think there may be some representatives to here, one of the national funders here in the UK, particularly around randomised controlled trials in public health and in clinical practice. And they are very invested in women's health at the moment, have a number of different groups, came about from a big workshop. One of the groups is looking particularly at this, but at the big workshop, one of the speakers said that women were being excluded from the vast majority of the new obesity-type medications. And that shocked me and surprised me. So that got me sort of thinking, okay, we need to look at this. And so I've been doing kind of in my free time. Anybody want to help with this, let me know. And literally all I'm doing is collecting all of the COVID randomised control trials, all of the new obesity-type randomised controlled trials, and extracting their exclusion criteria, particularly around gender and sex, the proportion who end up actually being recruited, and if they've provided it, or if not, then my plan is to say they haven't reported it. If they've reported it, the actual differences between women and men, and any information on why they are different. So it's really preliminary work. What I can see is that there's a small proportion of women, a small proportion of the GLP-1 receptor agonists that exclude women who are pregnant, who are planning to get pregnant or are lactating, and it's really preliminary, still seeing this difference in terms of how many, the proportion of women who agree to be in the trial, and it's ongoing. So I've said there's very little research on this. There are comments, and what research there is sort of suggests that there's a range of factors. There's certainly where it's been looked at, younger people are less likely to enroll, but particularly in women compared to men. A common reason is that people are too busy, and that's, again, somewhat more common in women to men. But these are small numbers and a small proportion of the trials. It's something that's not reported. And so, I'll go back. Some of the solutions, I think, have to be collecting this information. It's a little bit like the NICE guidelines. We can't expect that to change until we start to push for people to look at this and go beyond. This is a conference about women's health, but also looking by ethnicity and social geography and social class, and then trying to understand specific to that reasons why they may not participate in research. I think some of the things that we increasingly do now need to be covered everywhere, and that is, you heard an amazing talk from Karen earlier about involving the people who this really matters to when you're designing your studies and going them forward. Going to the places where they are to collect data, thinking about electronic health records and other more remote sources of data that can lessen the burden that there is on participants in randomised controlled trials. These all have their pros and cons, and there are still some things that we would want to collect in real time, in real people, rather than rely on these remote resources. But I think we need to understand better who does and who doesn't come into the randomised controlled trials and for what reasons. And I will finish there.
Thank you. Thanks, Deborah. It's a really interesting, different way of considering underrepresentation by looking at who does and who doesn't agree to participate. But it does reflect what we kind of already know about people, racial and ethnic groups, also not participating for complex reasons, or maybe simple reasons like being not having enough time, or not seeing themselves as important enough. Again, we really don't know. So does anybody have any questions to ask about that? Hi, Andrew.
Hi, Andrea Deneve, United States. More of a comment and more related to the GLP-1s. Some of the companies have specifically excluded women of reproductive age because they're aware that a very common condition, polycystic ovary syndrome, is frequently associated with obesity, and there's resumption of ovulation and fertility with weight loss. And this is particularly cynical for a certain European-based company in that they are marketing the product for use in infertility patients and in women with PCOS. They're doing direct marketing to physicians. In the US, the Food and Drug Administration has required a post-marketing survey for one of these agents, but not for all of them in the class. And they have not yet required a study in women of reproductive age. And I think the situation should be very similar to that with type 2 diabetes drugs, where to bring a drug for market for many years, it was required to do a cardiovascular disease outcome study. So perhaps we can all, advocate and pressure for this, because we have no information, and those of us who treat infertility really don't have anything to tell our patients when they take these agents.
Yeah, I think you're absolutely right that there are conditions where we would expect there to be randomised controlled trials. I should say, as with the other studies that have looked in this area, the obesity drugs that I'm pulling out and looking at, I'm only looking where, and a bit like the NICE guidelines, where it's an outcome that you would expect to be in women and men. So there's no reason why you wouldn't expect them to be equal. But you're right, there are conditions where actually we would expect there to be more research, and PCOS is an example.
Yeah, maybe I'm being naive, but I'm surprised that they're not targeting PCOS. I mean, it seems like low-hanging fruit for a GLP-1.
I can speak loudly.
Yes.
Yeah.
They absolutely refused to. A number of us proposed trials over a number of years, and they're so worried about the issue of liability for if there's pregnancy that they haven't done the studies. But then to turn around and promote.
Yeah, it's cynical, very cynical.
Yeah, and there are ways around doing the trial in terms of, monitoring women and talking to them and involving them. Yeah, it is very cynical.
Thank you. Are there any other questions related to the participation trial? No? Okay. Nothing online? No. Thank you.
No.
So I'd like to thank all the speakers, and also thank all of you for your attention for this very interesting session. Thank you.